Okay, I'm going to assume you can see this and you can all hear me unless someone shouts and tells me otherwise. So as Alex said, my name is Jacob. I'm a neurology registrar, so I'm ST5, so I'm about halfway through my specialty training, based in the southwest of England, currently in Plymouth. I am going to do this first session on seizures, which is one of the most common neurological presentations to hospital. I'm going to focus it around the diagnosis and investigation of seizures, okay, with a little bit on management. And then for those of you who would like, I'm going to do more specifically about epilepsy itself next week. So what is this talk going to be about? It's going to be about the headline, big, important take-home messages, okay? So what a seizure is. We're going to talk about how to diagnose a seizure, and basically that's clinically through the history. So it's something that anyone can do, and particularly any junior doctor who's clerking a patient, seeing them in ED or MAU, you know, you can absolutely do this and get that patient going down the right track of, is it a seizure or is it something else that needs a completely different management process? Going to talk about the important initial investigations and about the important differential diagnoses, and then a bit about the initial management priorities, although that will depend a little bit on the situation, and I'm not going to go into too much detail, but I'm happy to take any more questions about it at the end. So this talk is not about epilepsy. That's next week. If you're not put off by this one and you're interested, please do come. It's not going to be about how to interpret an EEG, because that's not something we do. Well, it's not something I do as a neurology trainee. I don't know how to do it, to be perfectly honest, and it's definitely not something you're going to need to do as a foundation doctor. It's also not going to be about lists of hundreds and hundreds of anti-epileptic drugs, so don't worry about that. So to start off with, I'm just going to got 3 cases with 1 MCQ on them each, just to kind of set the scene. So if you would be happy to, if you just get your phone or your computers and just go onto vvox.app, which is a kind of online polling platform which you may have used before, and then just add in that session ID. It comes up with a boxing into session ID. If you just put that in, and I've just got a few MCQs, it'd be good to just get a kind of spread of what people think initially, and then we're going to do the bulk of the talk and then repeat the questions afterwards and see if people have changed their minds. Okay, so the number comes up later if you haven't had a chance to do it at the moment, but vvox.app is the website. So 3 cases to start with. They're all cases I've been involved with in the last few months, so real life cases. In Plymouth, we, as neurology trainees and neurology doctors, do the stroke service as well. So we spend quite a lot of time in ED seeing people presenting at the front door with something neurological, and the key question really is, you know, is it a stroke? Do I need to thrombolyze them, or is it something else? You know, is it a seizure or what? So, you know, a big part of what we do is about trying to get that diagnosis right at the start, and it's just a really nice kind of clinical approach. You know, it's like being a proper doctor. You know, you see someone, you take the history, you do the examination, you decide what you think's going on, and you start the management. So this was one patient I saw a few months ago. He got helicoptered in as a stroke alert. You know, this person has got slurred and unusual speech. We think he's aphasic. You know, I think he might be having a stroke and might need to be thrombolyzed. So get him to hospital as quickly as possible. He's a 63-year-old man who was pretty well, drank a little bit too much alcohol, worked as a caterer, and took a few kind of fairly standard medications. When I saw him at the front door, he had actually got quite a bit better from how he was, and over the following half an hour or so, he basically got back to normal. So I didn't need to worry about kind of thrombolyzing him as a potential stroke, because obviously if someone's back to normal, you're definitely not going to thrombolyze them. So it quickly became an issue about what had happened. You know, was it a stroke that got better, so a TIA, or was it something else completely? So he couldn't remember. So I spoke to his wife over the phone, and this is basically what she told me. She said, we were at home, I saw him fall down, he was on the floor, he became quite stiff and clenched his jaw, and then he was just staring forwards and not responding. So kind of unresponsive is something you get told quite a lot about patients. He was kind of unresponsive, and that she was talking to him and he just wasn't responding and didn't seem to realize that she was there. And it just stayed like that for maybe a minute or so. And then he started trying to speak after a few minutes, but was really confused and just not at all himself, which is when that he got brought in as a possible stroke. And then by the time I saw him, which was basically about an hour after it started, he was back to normal. So he fully recovered over about an hour. So with that, if you just quickly tap in what you think the most likely diagnosis is, you know, it doesn't matter if you're right or wrong, just go for your gut feeling. I'm sure you probably will be right. Just see what kind of a spread we get. I'll leave that up there for about 10 seconds more. Okay, let's see what we got. Okay, so most people are going for seizure. I guess this is a talk about seizure, so I think that's, you know, probably quite a good bet to start off with. A few people going for TIA, syncope, and stroke. Okay, cool. So case 2, different situation. Someone I saw in our kind of first fit clinic a few weeks ago. 16-year-old girl came in with her mum. Background of anxiety and depression, was under the CAMS team, so the Child and Adolescent Mental Health team, and was on sertraline, studying hairdressing at a local college. And she described about 6 weeks of blackouts. So again, it's something you hear quite a lot, you know, unresponsive or blackouts, you know, that's something you just need to really pick apart and work out what it is. She's been having these up to 5 times a day, so quite a lot, you know, day in, day out for 6 weeks, 5 of them. History from her was that she gets a little bit lightheaded and then just feels like she zones out. She's not able to do what she wants to do and can't recall everything, but she says that she can hear what's going on when this is happening. And then the mum says, well, what I see is that she's kind of shaking her limbs, she's kind of back arched a bit, her eyes are open, legs are going, arms are going. The longest one lasted about 15 minutes, but it might be as short as 5 minutes. And she got back to normal pretty quickly after each one. So, same question. What do you think the most likely diagnosis is for this 16-year-old girl? Okay, I'll stop it there. Seizure, syncope, dissociative attack. Okay, great. I should say I'm using dissociative attack as my kind of favored term for what's also known as a non-epileptic attack or a pseudo seizure, just in case, just to clarify that. Sorry, I should have done that with the last one. Okay, good. And then final case, someone who got admitted to hospital, so ended up on the medical assessment unit, 35-year-old lady, well, PE teacher, no medicines, no nothing else. Her partner had seen her in bed the night before, just suddenly become unresponsive. So she actually kind of looked like she lost consciousness. She was pale, she had jerking of the arms and legs, and this all lasted maybe 30 seconds or certainly less than a minute. And she came round, you know, not immediately, but pretty quickly over 5 minutes. And she then had another event, and that's when they thought, yeah, we need to get to hospital. So I haven't given you all the information there. Slightly different question. What do you think if you had to pick one of these investigations would be the most important? You know, what one would you choose if you could only pick one of these? So I'm thinking in terms of making the diagnosis and also not missing something. No, not missing something dangerous. Okay, let's see what we've got there. Okay, so a bit of a spread there. CT heads most popular, and then a bit of a spread around all the others. Okay, great. So just keep those in mind. We'll come back to all of those at the end. So bit more of me talking. So what is a seizure? Again, you know, big, simple things to hold in your mind. A seizure is just extra electricity in the brain. Okay, I'm sure you all know this. But it's really important just to hold on to that. I think, you know, as you're studying in medical school, what I found is you're pretty good at these kind of definitions and kind of, you know, the scope of lots of, you know, different kind of medical and surgical conditions as you come out through medical school. And then during your foundation years, you basically spend 2 years kind of forgetting this kind of stuff and just, you know, doing the jobs, you know, learning how to run a ward round, how to prescribe medicines and the right doses, etc. And then I personally have kind of spent my years since foundation training, trying to relearn all this stuff. So if you can hold on to it, great, but you can always relearn it in the future if you need. But for a seizure, just remember the seizure is extra electricity, okay? My first key point here of the talk really is that anyone can have a seizure. There's a kind of bit of a misconception that seizure equals epilepsy, but that absolutely is not the case. Okay, there's loads of reasons why people can have a seizure, and any normal person can have a seizure. We've all got a seizure threshold. Okay, I've listed a few things there that's by no means exhaustive, but if I finish this talk and go and drink 2 liters of vodka, I'll probably have a seizure. If I inject myself with a load of insulin and give myself a terrible hypo, probably going to have a seizure. Okay, so all these things here can provoke seizures in any normal person. Okay, yes, people with epilepsy can have unprovoked seizures, so they're obviously more prone to it, and they of course can have a seizure for kind of less of a reason. So they might have a seizure only after having a small amount to drink or having a mild hypo. But anyone can have a seizure. And if that's someone's having a new seizure, you really need to think hard about why that might have happened, because a lot of those need very specific managements. So seizures, as I'm sure you know, we call them either focal onset or generalized onset. So if it starts in one part of the brain, it's focal onset. People might not lose awareness then. They might just get a bit of jerking of one limb and then it settles down. They kind of remember it all and they never kind of become confused or anything. But it can be focal onset that causes kind of reduced awareness, or it can be generalized onset, and all of those are going to cause kind of amnesia for events and usually have quite a prolonged recovery afterwards. So very briefly, broadly, seizures are typically brief. Okay, so the brain's got pretty good mechanisms for shutting down seizures. So generally, a seizure shouldn't last more than a few minutes. Of course, if someone's in status, that's a different situation. They're going to be really sick, but the vast majority of seizures, don't last any more than maybe a minute or 2 or 3 at most. For people who have more than one seizure, so typically people with epilepsy, they tend to be the same type of event again and again. So that can be helpful diagnostically. Beware the patient who comes in and says, "Oh, doctor, I've had another one of my TIAs. I'm having one every month." People don't have the same type of TIA again and again. Okay, that's much more likely to be a seizure. And leading on to that, just remember that seizures typically give you positive symptoms. So you get extra stuff, extra muscle contraction, you get extra movements, you get extra sensations of hallucinations or smells or whatever. Whereas strokes and TIAs and syncope, you kind of lose your blood supply, so you get negative symptoms. So you lose power, you lose speech, you lose vision. Yeah, and so with a seizure, you can get that kind of typical post-ictal phase, which is really helpful diagnostically, but only in generalized onset, or if you've got focal onset with altered awareness. But to be honest, those are the ones that come to hospital. So most of those, most of the seizures you're going to see in hospital will have some kind of post-ictal phase. Okay, so that's all I'm going to say about what a seizure is. Very basic. How do you diagnose a seizure? Second key point: a seizure is diagnosed clinically. Okay, there's no test that kind of confirms a seizure. There's no test there's certainly no test that rules out a seizure, and there's certainly no test that rules out epilepsy. It's basically all just done on the history. Okay, so as a junior doctor, this is what you're doing with all patients, really, isn't it? You're taking a history. I think to diagnose a seizure, it probably needs a little bit more effort, to be a little bit more involved, and that's because normally patients can't remember exactly what happened. So you normally have to go and find someone who saw what happened. So you need to get a collateral history from a witness. Okay, and when you're taking the history, just really think about what happened before, what happened during, and what happened after. Okay, it's really helpful structure. If someone's got a video, then brilliant, but I would always recommend kind of documenting in the notes your assessment of what that video shows, so it's really clear. Also in the history, I'm not going to tell you everything to ask in the history, but obviously if someone's got known epilepsy or had seizures in the past, that's really helpful to know, okay, because they're obviously being more prone to having seizures. Doesn't mean that whatever they come in with this time is a seizure, but it just changes your likelihood. So you would always want to ask that in your history. So in terms of diagnosing a seizure and taking the history, so this is, a kind of very brief kind of schematic, table about what's the typical features that are happening before, during, and after an event, according to whether it's a seizure, and then what I think are the main 2 differentials, which are syncope, so lack of blood flow to the brain, causing a faint, or a dissociative attack, or also known as non-epileptic attack, or a pseudo seizure. So you might get a warning with all of them. Okay, syncope, you're thinking about things like kind of lightheadedness, something cardiac like palpitations or chest pain. Okay, seizures and dissociative attacks a bit more variable, but people do get a little bit of a sense that it's coming up on them, like an aura. In terms of during, the time frame is really helpful. Okay, and again, that's probably something people aren't very good at necessarily documenting, because if you take a really good history and you've explained exactly what happened before, during, and after it, you've got a really good sense of how long it lasts. But the person who comes and looks at it next actually can't really get that from your notes. So definitely just try and document or work out from a witness, was it something that lasted seconds or minutes or longer? Okay, that's all it needs to be. Seconds suggests a syncopal event. More than 5 minutes, someone who's not really unwell suggests that it's not a kind of generalized seizure. Whereas, as we said before, a seizure is typically just a few minutes. Again, kind of stiffness versus floppiness is really helpful. Remember, seizures extra activity, so you get stiff. Syncope, you fainted, you go floppy, you go pale. So it's just they're kind of opposites, but people aren't particularly good at describing unless you specifically ask them. In terms of differentiating a seizure from a dissociative attack, that can be a bit tricky. More commonly, someone's eyes are closed in a dissociative attack and open during a seizure. If someone's going blue and cyanose, that's much more suggestive of a seizure. Lateral tongue bites are really suggestive of generalized seizures. Okay, incontinence is not that great, because a lot of people will be incontinent with syncope. And just going back to the tongue bite at the tip of the tongue is not such a good sign, but a lateral tongue bite, big lateral tongue bite, that's very suggestive someone's had a convulsive seizure. And then afterwards, afterwards is really helpful, because sometimes you haven't got a witness for actually what happened during the event, and it's more about how the patient is afterwards. Even if you have no idea what happened to someone for a minute while they're in the kitchen, but then they came out and they're staggering around and they're confused and they don't know who their wife is, they don't know where they are, and it takes them 2 hours to recover, that's really suggestive of a generalized seizure. Okay, whereas syncope and dissociative attacks should be pretty quick recovery. Okay, so quick schematic about differential diagnoses to hold in mind when you're doing the history. So as we said, seizure, syncope, dissociative attack. Okay, if from your history you think that this is most in keeping with a seizure, then I would say the next stage is to think about whether it's a provoked seizure. Okay, so is there anything in the history or their initial investigations to suggest a reason why they've had this seizure? And if not, is it an unprovoked seizure? Okay, you're then going to go on and think about whether this means they've got epilepsy, but I guess you're not going to be the person making that diagnosis. That's normally a specialist diagnosis in terms of a first fit clinic. Okay, of course, people with epilepsy can have both provoked and unprovoked seizures. In terms of syncope, that's a whole separate talk in itself, so I won't dwell too much on that. But if you're through your history, you think someone's had a syncopal event, don't stop there. Think about why they had a syncope. Is it a reflex syncope like a vasovagal? Is it some kind of cardiac outflow tract obstruction like a aortic stenosis? So listen for the murmur. Is it an arrhythmia? Look at the ECG. Is it orthostatic? Have they got a postural blood pressure drop? Syncope can kind of give you a little bit of jerk. People who faint can get a little bit of jerking. That's often called a kind of convulsive syncope. That's not a true seizure, but definitely people can have jerking and twitching after a faint. Some people would say that a syncope can actually trigger a generalized seizure. That's perhaps a little bit more controversial, but I think that probably is the case for some people. So rarely, I think people who faint can then go on and have a seizure, so it's provoked by syncope. So these things aren't completely mutually exclusive. Okay, one thing can lead to another, and there's certainly plenty of people walking around who have epileptic seizures and dissociative attacks. Okay, so these things can coexist, but you should do your best to try and differentiate them. Okay, fine. So sticking with diagnosis, so I think the history is how you make the diagnosis. The examination is then you're basically looking for anything that might have caused a seizure. and also to look for any injury, so any consequences of the seizure. Okay, so big things, are they unwell? Do they look like they've got sepsis? Are they febrile? Okay, and particularly if you've got someone with new sepsis and a seizure, you're thinking about brain infection, meningitis, encephalitis, and that's important to think about because you need to give slightly different antimicrobials. If you give your general kind of pneumonia or urosepsis type antibiotics, they're not necessarily going to penetrate the blood-brain barrier. So if you're thinking meningitis, you'd give a specific high dose things like ceftriaxone. And for an encephalitis, for an infective encephalitis, that's basically always viral. So you need to give them antivirals. So important to think about that at the back of your mind. We do see lots of elderly people in particular who get septic for other reasons, so, like pneumonias, like urine, who then have a seizure, kind of provoked seizure from sepsis, and they don't have, a meningitis or an encephalitis. So that is quite common. But I think in most cases, you'd at least cover them with the antibiotic, with the kind of meningitis, encephalitis, antimicrobials until you know definitely what the source is. You do have to do a full neurological exam, I'm afraid. Really helpful to document the GCS. If someone's really drowsy and possibly post-ictal, do the GCS, and then in a couple of hours later you can compare it and you say, yes, this person's improving in the way I might expect someone to after a seizure. And if they've got any focal deficits, so unilateral weakness, hemianopia, something like that, that suggests a structural brain problem. Maybe a stroke. Occasionally a stroke can trigger a seizure, or more likely something like a brain tumor or another space occupying lesion. And then a few other things on general examination. So lateral tongue bites, we talked about, if the patient can't volunteer it, you just look for them, okay? Look for injuries, think about the cardiovascular side of things, so murmurs, lying-standing blood pressure as well. Okay, fine, so that's diagnosing seizure. History really to make the diagnosis, collateral examination to think about what might have caused it and any consequences like injuries. So investigations, I've not got too much on this. ECG. ECG is basically the only mandatory examination for someone coming in with a suspected seizure, okay? Nice guidelines, say any adults with a seizure should basically have an ECG, bloods including electrolytes, and a blood sugar. So those are your big three, okay? And I think that probably goes for whether you think it's a syncope or a seizure or a dissociative attack. I think all of those things are still relevant. But if you think it's a seizure, you have to do those three. And an ECG is meant to be the most important just because of the risk of missing something like a cardiac arrhythmia that's a cause of syncope, or because seizures can sometimes cause cardiac arrhythmias as well. Often people end up getting a head imaging, usually a CT. That's not always necessary, but if there's any kind of concern about a structural brain problem, or particularly if someone with a new seizure, particularly someone like an older adult, they'd normally get some brain imaging. Someone with epilepsy who's having seizures, a few times a year, if they come in with a seizure and they're just taking a bit longer to come round, and that's why they're in hospital, but then they do fully recover, that person typically doesn't need brain imaging. Just a little bit about EEG. So EEGs are really helpful if someone's had one unprovoked seizure, and then we typically don't say that's epilepsy. You need 2 unprovoked seizures to have a diagnosis of epilepsy, or 1 unprovoked seizure and something that suggests you're at higher risk of having more, such as an abnormal EEG or an abnormal brain scan. Okay, so if someone has 1 seizure and an abnormal EEG, we typically start them on anti-epileptic medicines, or at least offer that to them. So it's helpful in that situation. It's also really helpful from a kind of acute admission point of view in terms of someone who's had a seizure and they're not waking up. So then in that situation, you really want to know if they're having ongoing seizures, little ongoing seizures that are keeping them drowsy, or whether they're just someone who takes a long time to wake up. And that can be really hard to tell clinically. And obviously if someone's having ongoing seizures, you need to treat that, and they're going to do much worse if you don't. So an EEG is really helpful to look for ongoing non-convulsive seizures in a patient who's kind of persistently drowsy. But EEG can't exclude epilepsy. So there's plenty of people with epilepsy walking around who have normal EEGs. And I'd also just thought I'd point out that the NICE guidelines specifically state that you shouldn't do an EEG where you think someone's had a syncopal event. Okay, so again, it all kind of starts from the history. The history suggests a syncope, don't do an EEG because you could easily get a false positive, and that's just going to muddy the waters. And if someone ends up on anti-epileptic medicines for the rest of their life unnecessarily, you're not doing them any favors. There's a few other things. You might want to do a general septic screen if they're febrile, like we kind of mentioned, but that might include a lumbar puncture. That's basically how you diagnose a meningitis or encephalitis. Anticonvulsant levels, are probably not majorly helpful, to be honest. The main reason we use them is if we think someone may not have been taking their medicines. So someone with epilepsy and you're not sure if they're taking them, and then if you do a level on their admission bloods and you can't detect any of the anticonvulsant, then you kind of know that that's the reason why they've had a seizure. So that's where they're most helpful. The other one is when someone's on phenytoin. So if you load someone with phenytoin, you want to kind of tweak their ongoing maintenance level, because phenytoin is kind of metabolized differently by different people. You have to do a level to kind of guide that, but those are the two main reasons we use anticonvulsant blood levels. So moving on to management, this is the last section. Going to depend on the situation. I think the first main priority is to think, does this person have ongoing seizures? Someone's come in with some kind of episode. If they've not fully recovered, is it because they're still seizing? Okay, and you can do that, like I said, with an EEG, but that's not that available. You can generally only get that in Monday to Friday 9 to 5 where I work, and it's probably less available in other hospitals around the country. So what you can do is just look really careful. It really is just inspection. So if you know that someone started with a seizure on kind of one side, then you just want to look at that side, and if there's little twitches, if you see like a face and an arm twitching at the same time, face and arm equals somewhere in the brain is the same as a stroke. So if you see little twitches, if you see kind of twitches of the eyelids or repetitive movements of the eyes, that's quite suggestive as well. And often in that situation, you're going to need to get support and get them into a safe place, but you're probably going to just need to give them some more medication to see if they wake up. So ongoing seizures, whether they're convulsive or non-convulsive, is basically Statusepilepticus, which, as I'm sure you all know, is a medical emergency and basically you need to manage with an ABCDE approach. I'm not going to go into too much detail about this, but I think it is always important to bring this up when talking about seizures. So the key things that you can do and immediately is to get the patient into the safe position. Okay, put oxygen on, high flow oxygen, check their blood sugar, and make sure there's appropriate people around. Okay. I don't think you would be on your own managing this very often. I think people either come in with status pre-alerted by the ambulance and they go straight into resus, or typically what I found is if it happens to someone as an inpatient with a seizure, then they generally get a kind of an arrest call or a medical emergency team call, so at least there's kind of a group of people going up. But whoever gets there first needs to do those simple things. In terms of medications, it's going to vary a little bit according to where you work in terms of local guidelines, but basically it's benzodiazepines are first line. And in hospital, you typically use IV lorazepam, somewhere between 1 to 4 milligrams as a one-off dose, and then you can repeat it again after about 5 minutes if they're still seizing. Okay. There are other benzodiazepine options, so PR diazepam and buccal midazolam. They're more used in the kind of pre-hospital setting and ambulance settings, but if you don't have access, for example, then they're perfectly reasonable. But normally in hospital, we use IV lorazepam. Most, statuses, most ongoing seizures will terminate with benzos. But there's a few different second line medications that you'll probably come across, and I'll just mention them briefly. And basically the key thing is they're kind of all pretty much the same. They're all given IV over about 20 to 30 minutes, and they're all equally effective broadly at terminating seizures. Phenytoin is the one that's historically been around for the longest, but valproate and then more recently levetiracetam or Keppra can be used. I'll just make a quick point about the dose of levetiracetam is 40 milligrams per kilogram. Okay, there's I just say if you're going to use that for someone who's actively fitting to try and terminate it, make sure you give that full dose. Okay, so 40 milligrams per kilogram in whatever a 50, even just a 50 kg person is going to be 2,000 milligrams, so 2 grams. A kind of standard, I'm not quite sure. Let's give someone some Keppra because they've had, because they've got some seizures, which I see quite a lot, is someone just getting 1 gram. So that's not a full load. Okay, so just be aware of that dose. Okay. Beyond that is anesthetic agents, okay, and that means anaesthetists or intensive care. So when you're giving the second line medicines, they need to be aware. The third line is taking someone to intensive care, assuming that that is the right thing to do for that patient. Okay, so firstly, are there any ongoing seizures? If so, needs to be managed as an emergency in the appropriate supportive setting with enough help around. Do the simple things: oxygen, blood sugar, positioning, and then think about getting some medications. Fine. What about if it's just someone who's come in with some kind of event, some kind of loss of consciousness event? You've taken the history, you think it's a seizure, and then you want to work out if it's provoked or unprovoked, which basically is the same thing. Can they go home and have outpatient follow-up safely? Now I know that you might not be sending people home independently, but I think particularly if you're working in the emergency department, they're pretty busy. You're going to discuss it with a senior, but they're basically going to make their decision based on the information that you give them. So you have to be really comfortable with yourself that you've taken appropriate history, you've thought about the different things that might have provoked a seizure, and that you're happy they're not there. Okay. So that's going to be the things we've discussed: the history to decide that you think it's a seizure, the examination and the OBS to think about what might have provoked it, and your initial investigations. Okay, think about any injuries that might need addressing. If you've got any suggestion of something that's provoked it, like an infection, like a low sodium, like a low blood sugar, if someone's withdrawing from alcohol, then it's all going to need managing in a specific way, okay? And they're probably going to need to stay in hospital while we correct that underlying thing, okay? If, however, there's nothing to suggest a cause of seizure and it's just something that's come on out of the blue and they're fully recovered, then that person doesn't need to stay in hospital, okay? But they do need some kind of follow-up. So if it's a kind of first fit and they're not known to have epilepsy, then they need to be referred to the first fit clinic, and that will depend, the process for that will depend on where you work. NICE guidelines say that suspected first seizures should be seen urgently, which they say should basically be within 2 weeks. So it's urgent, but it's not super urgent, okay? If someone's got epilepsy and they've had a seizure, but they fully recovered, I think you just need to make the epilepsy team aware. And often the best way to do that is to get in contact with the epilepsy nurse, either by email or phone, or if you've got a neurology registrar around, you can drop them a line. But I think their regular team's going to want to know if they've had a seizure that's brought them into hospital. Okay. If someone is going home, just remember to give them some safety advice. Okay, tell them not to drive. Okay, tell them to avoid heights, don't go swimming, have a shower, not a bath, and then just to avoid things that would increase the chance of a seizure in anyone. So don't drink, don't go home and have an alcohol binge, try and get really nice, stable sleep. And I think I'll say that, ideally, you should have someone around you for the next few days, because, if it's going to happen again, it's probably going to be in the next few days at the highest risk period. Okay. In terms of the driving, you don't have to tell them the specifics, because if you're referring them on to a kind of first fit assessment, that's the final decision is going to be made there. But essentially they shouldn't drive until they have that specialist assessment. And if they do ask more than that, for a seizure, it's at least 6 months. It might be up to 12 months depending on the results of their tests, like the EEG and things. Okay, so just the last couple of slides. For inpatients with seizures, pretty much everything we've discussed applies already, but I was just going to make a couple of kind of specific points. If you're called to someone on the ward, they've had a medical emergency, or a nurse has just said, oh, this person had a seizure, well, I think they've had a seizure, but they're okay now. If they've got known epilepsy, just think about the medicines, okay? It's really common for people with epilepsy who might be on slightly complicated regimes, who might not be swallowing properly because they're unwell, etc., to not be taking those medications appropriately, okay? And then the other thing is antibiotics. Some antibiotics, things like ciprofloxacin, levofloxacin, are really notorious for lowering seizure threshold, and might be a reason for why they've had a seizure. So you think about changing those to something else appropriate. If someone doesn't have epilepsy, you need to think about everything we discussed already in terms of all those provoking factors, but really think about alcohol withdrawal. Okay, has someone taken that alcohol history correctly when they got clerked? It's now 48 hours down the line and they're having a seizure. You know, that's a real classic time frame for having an alcohol withdrawal seizure. Okay, great. That's all the bulk of what I wanted to talk about. So we're just going to go back to the case now and see if we change our minds about anyone and any answers, and I'll let you know what I think the right answers are. So this is our 63-year-old man who was helicoptered in, drowsy and slurred speech, who got better over an hour and had an episode when he'd fallen to the ground and got stiff for about a minute and then being confused afterwards. So second chance on what this one is. What do people think? I think seizure was the top one last time. Okay, so we're sitting there. Okay, so this person had a seizure. Okay, I know that for sure because he'd come in about 3 times since then with more seizures. He had a normal EEG actually, but a slight abnormality on his MRI, just a bit of scarring that probably is the cause of his seizure. I think in the history, it's that hour of being confused and disorientated. You know, that's a bit too long for a syncopal. A TIA, I mean, again, yes, he had that kind of speech disturbance that then got better over an hour. That would be the right time frame for a TIA, but that history of stiffness and staring really wouldn't be typical. And people tend to not collapse with a TIA. Okay, I mean, you might get weak and fall, but you don't tend to like hit the deck and be vacant. That would be a bit unusual. Okay, so he was a seizure. I saw him with a kind of new diagnosis of epilepsy, because that was the second event he'd had, and he has unfortunately gone on to have a few more. Okay, what about our 16-year-old girl with a background of anxiety and depression who's been having up to 5 events a day where she gets a bit zoned out and she can still hear what's going on, but can't respond, bit of shaking, and lasts between 5 to 15 minutes. Okay. Yeah, so most of you are right there, absolutely. I think, so I saw a video of this one, which was really helpful. The mum came in with a video. I think most of the people who have their events filmed are probably dissociative because they go on a bit longer. People are a bit less worried about them. So, you know, it's not obviously not a, you know, not something to rely on, but most of the time they're dissociative attacks. I think with this, the fact she could still hear what was going on meant that, you know, she wasn't completely unaware. And the really rapid recovery, you know, one of them, she was kind of shaking and writhing for 16 minutes, then to just suddenly go back to the normal. That would be very, very unusual for a generalized seizure. Okay. It's too long for a syncope. Okay, and you occasionally get caught out with syncope where people are kind of sitting up and they kind of faint, and then people keep them sat up, and so they kind of keep having not enough blood pressure, you know, blood perfusion going to their brain. But if you lie someone down, then quickly they recover. So occasionally syncope can go on a bit longer, but generally it's just seconds. And the last ones, this is our kind of well lady who'd had a couple of events overnight of pale, unresponsive, some jerking, and came around over 5 minutes. So single most important investigation. CT head was far and away the winner last time. Okay, see where we are there. Okay, good. So not 100%, but we had a big swing to ECG. So I think some people were listening at least. So, you know, I think a blood sugar is important. You definitely would do one, but I think if you had to pick one, you know, it's probably her history is most in keeping with the syncope, and then she's probably had a bit of jerking, you know, as a result of the syncope. And actually, this lady had an abnormal EEG with some kind of heart block. I can't remember exactly what it was, but she ended up getting a pacemaker actually. So she was having syncope due to an arrhythmia. So the ECG for her was absolutely key. You know, if her ECG had been normal, she probably would have come under the neurology umbrella. But with that abnormal ECG, she was just 100% with cardiology and got that sorted straight away. Okay, that's me done. 5 key points to take home. 1, anyone can have a seizure. Okay, you don't have to have epilepsy. Seizures are diagnosed clinically, so you can do that. It's just, all it needs is a careful history from the patient and from the witness. Okay, you don't need any tests to diagnose a seizure. Think about seizure versus syncope versus a dissociative attack. If you think, if you think it's a seizure based on the history, just take it that one step further and think, is it provoked or is it unprovoked? And that'll just slightly change what you do in terms of keeping in the hospital or your initial management. And the key investigations for kind of any of these are ECG first and foremost, blood sugar, and routine bloods with electrolytes. Okay, thank you very much. That's a QR code for some feedback, please. If you get a chance to do that, we'd be very grateful. And if you've got any questions, we've got a bit of time, so I'm very happy to take any questions that people have.
Thanks so much, Jacob. That was fantastic, and a really good introduction to sort of seizure management. Certainly helped me structure how I sort of go through it in my head. We've got a couple of questions on the chat, which is done via Medal. Feel free to stick it in the chat if you've got any questions. The first one is sort of, how often would an EEG be done on a patient that's sort of already got an established diagnosis of epilepsy, if that is part of sort of routine management?
Okay, yeah, probably not that often, I'd say. You know, if you've got someone who's known epilepsy, then they're going to want to be on kind of long-term anti-epileptic agents, and they would have had an EEG, I'm sure, at the kind of time of diagnosis. So probably in that situation, it would be if you're worried they're having ongoing seizures, you know, so if they're kind of not waking up after a seizure, that's probably most likely. You know, occasionally, as I kind of alluded to before, some people can have epileptic seizures and dissociative attacks. So sometimes we arrange for people to have kind of a long-term EEG over a few days to try and capture an event. And that can be helpful to try and see whether there's an EEG correlate. So whether these kind of a new type of event is actually epileptic or not. And occasionally, if someone just kind of isn't really responding to medications very well, it can sometimes be a bit helpful just in terms of guiding the anti-epileptics we use. But I think, you know, the norm for that would be that people with epilepsy who have a seizure don't need another EEG.
Right, we've got another question from the audience. By safe position, do you mean the recovery position or anything that works?
Yeah, it's anything that works really. It's going to depend. You know, if they're really convulsing and kind of, you know, moving a lot, then you just want to make sure they're not by something hard where they're going to injure themselves. Typically, it means kind of on their side, you know, kind of safe airway, maybe holding their you know, jaw thrust, head tilt, with the oxygen on. It depends a little bit, you know, in terms of the situation, exactly how they are moving and what they're on at the moment. You know, in terms of a bed or a trolley or anything. But yeah, generally on their side is safest.
Okay, we've got a couple more. So we've got one that says, can you be aware during a seizure?
Yes, you can be. So, you know, seizure, there are loads of different types of seizures, and some of them are very odd, and I haven't, you know, really scratched the surface there. So, and never say never in medicine. But, you know, if someone's just having a focal seizure, so I saw someone today, for example, who's having little twitches of her face and her arm. So she came in with a seizure, kind of generalized seizure. She's got ongoing twitches. But she's completely with it. You know, she can talk to you, she can see what's going on, she's not confused at all. And she's basically got what we call kind of focal motor status. So she's got focal seizures that are just causing movement, and they're ongoing seizures and status, but she's completely aware. So yes, if you're just having focal seizures, then you can be aware during them.
All right, we've got another one. What is the difference between seizure and convulsion? Are they interchangeable?
I mean, I guess a convulsion is a kind of actual kind of movement, isn't it? So you can talk about kind of convulsive seizures. So I think that more refers to the kind of rhythmic, movement, whereas a seizure would describe any type of electrical overactivity in the brain, which could be a non-convulsive seizure, like an auditory hallucination or a myoclonus or something like that. So I think that they probably are used interchangeably, but they're not exactly the same. But in terms of the kind of emergency seizures that you see coming into hospital, most of those will be convulsive. So.
I've sort of got a follow-up question for that sort of myself. Is there any sort of non-tonic clonic sort of generalized seizures that sort of make you sort of really worry as the neurologist, just in terms of sort of potential diagnosis of sort of more dangerous sort of epilepsies, as it were?
I mean, in terms of ongoing seizures, obviously convulsive status is the most urgent, and that's generally what we mean when we kind of say status epilepticus, isn't it? Because with all the kind of electrolyte shifts and everything, they're the ones who are going to probably die quickest if we don't stop it. And then you've got kind of things like focal motor status, like what I was talking about there, where you want to try and get on top of it and stop it getting worse, but actually it can go on for quite a long time. And then you've got non-convulsive status, which normally people are just very flat and they're not convulsing. And again, it's something you want to get on top of pretty quickly, but they typically don't need to go to ITU and have anesthetic agents to do that. You can normally have time, sometimes over days, to be honest, to try one medicine and then another.
Brilliant. Thank you. Right, I think we've got one more. So the first investigations, ECG, blood sugar and electrolytes, done for seizures only or done for both seizures and syncope?
Well, that was taken from the NICE guidelines, of epilepsy, so it's that specific for seizures. But I definitely think that all of those are useful for suspected syncope as well. There's probably be a few more for syncope, lying standing blood pressure, anything else. But yeah, I think it goes for both. Although it was mostly targeted at seizure.
I think we've got another one. Can patients come out of status epilepticus on their own?
They can do, so as I said, the brain's normally pretty good at shutting down seizures. You have extra electricity and then there's lots of mechanisms to stop it, which is why seizures only last normally for a couple of minutes. The old diagnosis of status epilepticus was ongoing seizures for 30 minutes, whereas now we kind of more use a cutoff of 5 minutes, because once you get to 5 minutes, the chance of someone coming out by themselves is lower, but it doesn't mean that it's impossible. Okay, it's just that you're not going to risk not treating it, because the longer it goes on, the harder it is for someone to come out of status.
Okay, I can't see any more questions popping up in the chat. So I think, unless anyone wants to put anything there's all the thank yous starting to come in now. So yeah, thank you very much, Jacob. Our next session, everyone, will be on the 21st, so on Monday, and that's more around sort of managing people with established epilepsy and sort of anti-epileptics, which is a sort of common situation you come across as a foundation doctor in hospital. And we look forward to seeing you there. Please spread the word. This is a new neurology series for Mind the Bleep. And yeah, the more the merrier on board. So thank you very much, Jacob. Thank you very much, everyone, for attending. And we look forward to seeing you again.
Thanks a lot. Bye.